Whoa, gastroenterology. You're going to love this section. This section is easy because it's very linear, because it blocks out very nicely to say all of the esophageal disorders. No matter which one you have, all esophageal disorders can give you dysphagia. And you might say, what's the difference between dysphagia and odynophagia? Well, dysphagia is difficulty swallowing, but odynophagia is pain on swallowing. Dysphagia is I'm having difficulty swallowing. Odynos is the Greek word for pain, odynos. And dys means evil, bad. It's not semi-evil, not quasi-evil, not the margin of evil. Now, dysphagia, no matter what causes dysphagia, dysphagia can be associated with weight loss. So dysphagia and weight loss won't distinguish between the types of esophageal disorders. So whether you have achalasia, whether you have an incomplete or inappropriate relaxation of the lower esophageal sphincter, whether you have achalasia or you have esophageal cancer, it's dysphagia, or esophageal spasm, dysphagia. They all give you dysphagia, weight loss, dysphagia, weight loss, dysphagia, weight loss. Now the difference between that and esophagitis. Esophagitis is pain. Well, spasm gives you pain. Well, what's different about these? See, every one of these gives you difficulty swallowing. Dysphagia means difficulty. Difficulty swallowing. Abnormal swallowing. Incomplete swallowing. Achalasia is an incomplete relaxation of the lower esophageal sphincter. Cancer is a mechanical obstruction because the cancer grows into the lumen of the esophagus and blocks it. Spasm is the muscles. Remember, the GI tract is a big, long, muscular tube. The GI tract is a big, long, muscular tube. The whole GI tract, from the time it leaves your mouth all the way until the time it leaves your anus. The GI tract is a muscle. It's a muscular tube. If we were in the step one part of our brains, we'd be saying, well, what's different about this muscular tube inside the stomach? Well, inside the stomach is the only part that has 3 layers inside the stomach. Well, what's different in the esophagus? Well, the proximal esophagus is the only place that has skeletal muscle. What is different? What's unique? What is different? What's unique? What gives me the answers that I seek? What is different and unique? The proximal esophagus is the only place that has skeletal muscle in the top third of the esophagus. What is different and unique? What is different and unique? Esophagitis is all in the mucosa. What is different and unique? It's different and unique. What is different and unique? Zenker's diverticulum smells bad. Zenker's diverticulum malodorous. Zenker's diverticulum is an outpouching of the posterior pharyngeal constrictor muscles. Zenker's diverticulum smells like dumpster breath. Zenker's diverticulum is... Are you brushing your teeth with stool again? Are you eating shit sandwiches? Why? You should do your dating over the internet because you smell like mierda, pendejo. Because it's garbage in the back of your throat. Hey, what did you have for dinner tonight? Why should I describe it to you when I can show you? Chicken teriyaki again? That was disgusting. Smells bad. Rotty old things. Who's going to want a person like this? A man with Kalman syndrome. Rings and webs and webs and rings. The ring, it wants to be found. Rings and webs and webs and rings. And we have a Schatz Keys and a Plummer Vinson syndrome, Schatzky syndrome, and Plummer-Vinson syndrome, Schatzky syndrome, and Plummer-Vinson syndrome for rings and webs and rebs and rings. This is Intermittent dysphagia. Intermittent dysphagia. Well, what's different about Plummer-Vinson? What's different? So the first part, remember, let's remind ourselves about your test. The questions go like this. What is the most likely diagnosis? And on your test, what's the most likely diagnosis, frankly, is the single most frequently asked question. What is the best initial test? What is the most accurate test? What is the best initial therapy? What's the most likely diagnosis? What is the best initial test? What is the most accurate test? What is the best initial therapy? So we're going to leave this section on esophagus. And the reason that you're going to love GI is because all the sections in GI fit that thing perfectly. Because you're going to be able to walk into test day and go, bring it on, bring on that test, because I know the answer. I'm not here to pass. We're here to kick ass. And the other thing is the patients need you. I'm a fully functional clinical doctor. I've been in a regular medical floor, an emergency medicine department, a surgical ICU, and a medical ICU, a stroke unit, and telemetry, and I have seen patients in every one of these areas all within the last 24 hours. So you can take everything that we're doing and you can help it in the service of a suffering humanity. Just because we goof around doesn't mean we don't take it serious. This is serious, but you know, it's better to cry. It's better to laugh than to cry and all the horrible seriousness, and you'll be able to remember it better. So all esophageal disorders give you dysphagia. Anything that gives you dysphagia makes you lose weight. But they don't all make you smell bad. They don't all give you dumpster breath. The dysphagia is not always intermittent. They don't all give you pain. Achalasia is a younger person, usually under the age of 50, whereas cancer is usually over 50, esophageal cancer. Achalasia is a younger person that has both dysphagia to both solids and liquids at the same time. Both solids and liquids at the same time. It's an incomplete relaxation of the lower esophageal sphincter, for which you have to pneumatically dilate. Botox, cut it, shoot it, cut it, shoot it, dilate a balloon, cut it, shoot it, dilate a balloon, cut it up with knife, shoot it with some Botox, dilate it with a balloon, achalasia. Cancer is the older smoker, drinker, who's been exposing his esophagus to carcinogens for years, or with Barrett's esophagus turning into adenocarcinoma. Spasm is pain, but esophagitis is pain. Spasm is pain, but esophagitis is pain. Spasm is pain, esophagitis is pain. Now, ultimately, you make the diagnosis of spasm with manometry. Sounds sexist, doesn't it? Maybe it should be called womanometry or personometry. The same way that in achalasia, you could diagnose it with manometry, and you see failure to relax the lower esophageal sphincter. Spasm, excess contraction of the lower esophageal sphincter. But what's going to make me say manometry in spasm? Well, esophagitis gives pain. What's different about the pain of esophagitis from the pain of spasm? Very clear. You see, this is a test you're taking. And since it's a test, if they want you to know the answer, they have to tell you something. If they want you to know the answer, they have to let you know. Hey, they can't be just making you guess. Hey, I'm thinking of a number between 1 and 3. No, they have to give you something that tells you, hey, the pain of esophageal spasm happens at any time. It comes, it goes, and nobody knows. It's here, it's there, it's everywhere. I've got esophageal spasm, and it hurts the spasm. When I drink the cold drinks, it causes spasm, and I get the hurt, and I get the pain. Well, esophageal spasm comes and goes. It's not related to eating. That's the big thing. Esophageal spasm comes and goes. Although cold drinks bring it on, it can just happen. Esophageal spasm looks like a person who's having a coronary syndrome with chest pain. So you've got to look and see that the EKG is going to be negative, and the troponins and the CPKMBs are going to be negative, because it's not presenting the first thing somebody comes in and goes, oh, ¡Ay! ¡Ay, Dios mío! ¡Ay, doctor! Yo tengo dolor del pecho! ¡Ay! And you go, oh, shit, I bet it's esophageal spasm. Oh, I bet it's a nutcracker esophagus or you know, diffuse esophageal spasm, or you know, maybe it's just a chest pain because I got my nuts cracked in your esophagus, or your esophagus is cracking nuts, or no, you got to rule out cardiac. You rule out cardiac, and you go, why does that person have negative EKG, negative troponins, negative stress test, negative cath? And they have this crushing, horrible substernal chest pain. How did that happen? Well, the answer is because they have spasm, esophageal spasm. It becomes a bit like Prinz-Metal's angina. It's not related to eating, and the cardiac workup is negative. It's not related to eating, and the cardiac workup is negative. It's not related to eating, and the cardiac workup is negative. It's not related to eating, and the cardiac workup is negative. Then manometry, and ultimately, just like Prinz-Metal's angina, calcium channel blockers and nitrates. Calcium channel blockers and nitrates for Prinz-Metals, variant angina, calcium channels and nitrates for esophageal spasm. If it looks to you like I have not distinguished these between nutcracker esophagus and diffuse esophageal spasm, it's because I haven't. Because what's the difference in management? Whether it's nutcracker esophagus or diffuse esophageal spasm, well, yeah, there's a difference in the pattern of the manometry. There's a difference in the pattern of the manometry. There's a difference on the manometric pattern, but so what? Presentation, pain anytime in the chest, negative cardiac workup. Most accurate test, manometry. Treatment, calcium blocker, nitrates. It's the same. So you don't have to know the difference between them because it's the same management. Esophagitis. Esophagitis is pain that's only on swallowing. Pain that's only on swallowing because it's pain that only happens when it's rubbing against your infected and inflamed esophagus. It's pain that's only happening when it's rubbing against your infected or inflamed esophagus. It is pain that's only happening on swallowing. It is adenophagia, only on swallowing. And if the person is HIV positive, we give you fluconazole, and the fluconazole should make it get better. Okay, if you're HIV positive, you treat it only with fluconazole because fluconazole, the azoles, make your candida get better. So fluconazole should make it get better. And if it doesn't get better with fluconazole, what's the next best step in the management of this patient? I have pain that's only on swallowing, pain with dysphagia, weight loss, and adenophagia. And if it doesn't get better, you scope them. And if you're HIV negative, you scope them. Because that pain could be CMV. That pain could be herpes simplex. That pain could be aphthous ulcers. And the only way to diagnose them is if you don't get better with fluconazole or you're HIV negative. Esophageal candidiasis is an AIDS-defining disorder. Esophageal candidiasis will not get better with nystatin, swish, and swallow, which is a very, very common wrong answer. Why doesn't it get better with nystatin, swish, and swallow? It ought to get better with nystatin, swish, and swallow. How come it's not getting better with nystatin, swish, and swallow? And the answer is very straightforward, because it's simply not potent enough, it's not powerful enough to make it get better with nystatin, swish, and swallow. You need systemic therapy with fluconazole. Although amphotericin is effective, amphotericin is like having a television on a honeymoon. It's just not necessary. So, fluconazole. If it gets better, you're done. It's esophageal candidiasis. If it doesn't get better, you scope. If it's HIV negative, you scope. If it doesn't get better, you scope. If it's HIV negative, you scope, because herpes esophagitis and CMV esophagitis and Kaposi sarcoma esophagitis and cancer all need a biopsy. So everything here gives difficulty swallowing. So what's the difference? Achalasia starts at a younger age with both solids and liquids at the same time. The barium study can show a bird's beak. There's a wonderful picture of a bird's beak inside the Master of the Boards book. Barium studies can show narrowing. Most accurate test is manometry. Scope is often done, but scope is done because we just want to exclude cancer. I really don't think it's right to say that achalasia causes cancer. I think you should say it's associated with cancer. In other words, you have achalasia and you get down there and you scope, and a few percentage of patients, like 4%, you find cancer, that the cancer caused the achalasia or associated with it. I think we should not be using the word cause until we really know something that causes it. I think it's better to say we scope people more and we find more cancer. And then at the end of the day, even after you exclude the cancer, the manometry shows the decreased ability to relax. Then we could use pneumatic dilation. Now the problem with pneumatic dilation with a balloon, the problem with pneumatic dilation and a balloon is that if you don't put up enough pressure, it doesn't dilate. But if you put up too much pressure, it perforates. So pneumatic dilation is easier than surgery, but surgery is less likely to perforate it. Let's say that again. Pneumatic dilation is easier to do. It's an endoscopic procedure, and it doesn't perforate you as much. Pneumatic, it's easier, but once you get up to enough pressure to be sure you're going to dilate all of them, you end up perforating. Surgery is harder to do, but you don't perforate as much. And Botox, botulinum toxin, is used in those people who either refuse pneumatic dilation, that refuse surgery, and the problem with botulinum toxin is it wears off. And second, you have to deliver it by endoscopy anyway. So it's not like it's so easy. Pneumatic dilation, easier, but perforates more. Surgery is harder, but perforates less. I doubt you'll be asked the difference between them. Cancer. Cancer is the only one in which you must do a scope. And you must do a scope because it's the only one that's diagnosed by biopsy. We don't diagnose a spasm by biopsy. We can see something on barium, but we see something more on manometry. We don't diagnose esophagitis 90% of the time because fluconazole responds to therapy with fluconazole, and Candida, you don't have to biopsy it. Zenker's diverticulum is diagnosed by barium, seeing an outpocketing in the back of your head. Schottky's ring is diagnosed with barium. Schottky's ring is diagnosed with barium studies, and we do pneumatic dilation. We just dilate the Schottky's ring. Plummer-Vinson syndrome is associated with cancer. It's associated with squamous cell cancer. Plummer-Vinson syndrome is associated with squamous cell cancer. Plummer-Vinson syndrome is associated with iron deficiency anemia. We don't know why. It's not blood loss, by the way. It is not from blood loss. And you see it both on barium, and you can do it as an endoscopy. But the one that always needs endoscopy, because it always needs a biopsy, the one that always needs endoscopy, because it always needs a biopsy, is esophageal cancer, because it's a biopsy diagnosis. And since the esophageal cancer could be squamous cell or adenocarcinoma, particularly from Barrett's esophagus, you have to biopsy it. The treatment of cancer of the esophagus is surgery, radiation, and chemotherapy with 5-FU, 5-fluorouracil-based regimens. Matter of fact, 5-FU is the standard of care for GI malignancies. 5-FU is a standard of care, is the basis. We base the stomach cancer. Things are moved around. Fluorouracil, FU. You got stomach cancer, FU. You have bowel cancer, small bowel cancer, rectal cancer, surgery, radiation, and FU too. Esophageal cancer, 5 fluorouracil. So esophagus, FU, stomach cancer, FU, small bowel, FU, rectal cancer, colon cancer, FU, 5FU. Fluorouracil. All GI malignancies. Now, in the esophagus, manometry, good. In the esophagus, barium can show you an achalasia. Barium can even show you something on spasm. Barium, definitely for Zenkers and then surgically resected. Definitely for Zenkers and then surgically resected. Barium for rings and webs. Schatzky's is intermittent dysphagia. Barium, pneumatically dilate it. Plummer-Vinson syndrome, you see a distal esophageal web, distal esophageal, proximal, distal. Barium. But in the stomach, barium is terrible. Barium, no good. Barium, useless, lousy. So in this esophagus, endoscopy, only really needed for esophageal cancer. In the esophagus, endoscopy only really needed in the 10% of HIV positive people that don't get better with fluconazole. Scope for herpes and CMV. Scope for herpes and CMV. But in the stomach, endoscopy all the time. In the stomach, endoscopy all the time. In the stomach, endoscopy all the time. Because in the stomach, you can't tell it's Helicobacter pylori unless you scope. In the stomach, gastric cancer, can you tell that the gastric ulcer? 4% of the gastric ulcers have cancer. Can you tell without a scope? No. So in the stomach, scope and endoscopy, good all the time. In the esophagus, not so much. In other words, for scleroderma, systemic sclerosis, who do you know distributed his scleroderma? Did you know the artist Paul Klee had scleroderma? His artwork got smaller and smaller and smaller as time goes on. So everything becomes tight. And the other thing about scleroderma, it causes gastroesophageal reflux disease because it's an esophagus that doesn't contract, that doesn't relax, and you give them PPIs for their scleroderma esophagitis. So in the stomach, endoscopy, good. In the esophagus, endoscopy, well, we scope achalasia to rule out the small amount of association with cancer. Well, we scope the 10% of people who don't get better with fluconazole because it might be herpes, need a biopsy, CMV, need a biopsy, but it's 10%. We scope the ones that are HIV negative, but you don't need scopes for Schatzky's ring, that's barium. Distal esophageal ring and web, intermittent dysphagia, barium, pneumatic dilation. You don't have to scope for scleroderma, it's just acid comes out. So inside the esophagus, everything inside the esophagus can cause dysphagia. If it can cause dysphagia, it can cause weight loss. Not everything causes pain. So what you have in front of you here, how do I answer what's the most likely diagnosis? Solids and liquids. How do I answer what's the most likely diagnosis? Over 50, smoker, drinker with progressive. Smoker, drinker. First for solids, then for liquids. First for solids, then for liquids. First for solids, then for liquids. Spasm is a pain disorder brought on by cold drinks. Barium is okay, but manometry is most accurate. Exclude the ischemic disease and give calcium blockers and nitrates. So the final thing for this section is Mallory-Weiss. How come the Mallory-Weiss tear was not on these original sections here with all these other esophageal disorders? Okay, you're not smelly like you are with Zenkers and barium studies and surgical removal. So what's different that Mallory-Weiss is not the same as the others? Because Mallory-Weiss does not cause dysphagia. The difference between Mallory-Weiss and the others. The difference between Mallory-Weiss and the others is that Mallory-Weiss syndrome It does not cause dysphagia, and it does not cause odynophagia. It does not cause dysphagia. Does not cause dysphagia. It does not cause odynophagia. Mallory-Weiss is different because it's vomiting, retching, and you get like this. Mallory-Weiss. You vomit blood. Mallory-Weiss. And you vomit blood. It's a bleeding disorder because it doesn't go all the way through. Mallory-Weiss, bleeding. If it goes all the way through the esophagus, what's it called? All the way through the esophagus, it's called a Boerhaave. It's transmural. Goes all the way through, it's a Boerhaave. Goes all the way through. That's a Boerhaave. Mallory-Weiss is just retching, bleeding, no dysphagia, no odynophagia. You can diagnose it on endoscopy, and sometimes we use epinephrine injection. Epinephrine injection directly into it to try to stop the bleeding with epinephrine injection. Scleroderma is just reflux disease, and it's just peepee eyes. You should have enough information here to answer every question on your test and to be able to take care of patients too. Write to me. Hope to hear from you. Peace.